Parthiban, who is a neurophysiologist at our institute, Tata Memorial Hospital, Mumbai. Dr. Parthiban will be speaking on the intraoperative nerve monitoring. What are the techniques and pitfalls? Dr. Parthiban, if you are muted, please unmute yourself. And the IT, please unmute as admin. He has joined as admin.
Yes, I unmuted.
Yeah, we can hear you, Dr. Parthiban.
Thank you. Can you all see my screens? Hello?
Yes, Dr. Parthiban, we can see you. Yeah, we can see the slide well.
Right. Can we start now?
Yes, please.
Yes. Happy morning to all. Thank you, Dr. Poonam Joshi, for arranging this presentation for this Zoom meeting. Today, I'd like to talk about the intraoperative neurophysiological monitoring, which is used in routine thyroid surgery. I'm always thanks to our head and surgical units and also my students. I have no conflict of interest in this topic. What is intraoperative neurophysiology monitoring is? It is a electrophysiology methods to monitor the functional integrity of the certain neurostructures during the course of surgery. It is used to reduce the risk to the patient of any iatrogenic damage to the nervous system, and also to provide the functional guidance to the surgeons. The rationale behind the IONM, when we are using it for the surgical procedures, is to prevent the new neurological impairment and reassurance to the surgeons about the recurrent nerve and vagus nerve neurological status, and if so, modify the surgical strategy. There are always three concerns from the operative point of view. One is the surgeon's concern, another one the technical concern, the another one is a neurophysiologist concern. Coming to the surgeon's main concern, so they would like to know that the nervous system is still intact till that point of surgery when you're doing the dissection, and can safely node or thyroid gland be removed without causing the damage to the recurrent angina, and to ensure that safe R0 level resection. The neurophysiologist concern is to monitor the patients during the course of surgery and give the continuous feedback to the surgeon regarding the status of the recurrent angina and the vagus, and identify the false alarms, that is most important, and prognosticate the postoperative outcome. In this case, so who all needs the IONM? So coming to the point, for the clinicians, those who are transforming from generals to the specialists on head and neck oncology, and the junior clinicians, and surgeons who are facing more complicated thyroid surgery. When it comes to the history of the IONM, the application of IONM in thyroid surgery was initially proposed by Professor Donald in 1966 and followed by Postgraduate in 1969. And they implemented and found some interesting things on the recurrent angina identification using these electrophysiological methods.
Dr. Parthiban, sorry to interrupt you. Are the slides moving or we are on the first slide only?
No, it's moving.
Okay.
You're not seeing anything?
I can see only the first slide. I don't know if the issue is with me only or with everyone.
No, slides are not moving.
Okay. It's not moving, Dr.
But mine actually it's moving. Let me again share again.
Yeah, sure.
Now you can see that?
We can see, I think we can go to the slideshow mode, Dr. Parthiban.
Yeah, shared slideshow mode only.
Yeah, we can see the history now. Yeah, sure.
Oh, okay, now you can see the history, right?
Yes, we can.
Yeah. So in continuing with that same, that history, the application of IONM in thyroid surgery was initially proposed by Professor Donald in 1966, followed by the Flisberg in 1969. They found the interesting things with that identification of external branch of the superior angina as well as the recurrent angina during the thyroid surgery. You can see the next slide now, Dr. Poonam. Hello.
I can see the history slide, Dr. Parthiban.
Actually, you can see now.
Sir, in the slide share, no, sir.
Yeah.
So you can try sharing. You can try sharing and sharing the. There might be instead of screen share, there may be multiple options, sir. So I think you can just change to another option of sharing your screen or something, and
So let me see that actually.
IT, can please anybody help? IT, Vanda and Rohit, anybody can help?
Yes. Now we can see the full screen, sir.
So what about the next one?
Now we can see. Yes.
Right. I'm sorry. Right.
No, that's great. Please go ahead.
Yeah. Thank you. So again, the application of IONM thyroid surgery was initially proposed by the Professor Donald Shedd in 1966 and Flisberg in 1969, and found that this is a useful method to identify the external branch of superior angina as well as the recurrent angina in those course of surgery. The clinical significance and techniques of IONM is to see that actually how to use it. It's used to facilitate the identification and location of the recurrent angina during the surgery, and facilitates the exposure and dissection of recurrent angina, and facilitates the judgment of functional integrity and injury mechanisms of the nerves. Actually, the IONM concept actually comes up in a very profound manner, in the way that actually they used that some research respective of cohort study, and they found that intraoperative nerve monitoring can reduce the prevalence of recurrent angina injury in thyroid resurgeries, reoperations, and especially when they are doing that with and without thyroid surgeries. The IONM distribution is the year-to-year distribution. It shows that in redo thyroid is more important as compared to that normal in that way that proposed, but the concept is totally changed recent days. In those paper, actually, they said actually instead of recurrent angina injuries also very high without IONM, which is clinically significant, and permanent and total paralysis are very high in the without IONM as compared to with IONM model. The correlation of IONM results with the postoperative outcome is that intact nerve signal, when it is signal is intact till end of the surgery, and the negative predictive value which can be able to apply for that 99.6%. Which type of patients and procedures that require IONM is more important instead of using in random manner. The mass located dorsal side of the thyroid with suspected hemorrhage or thyroid cancer, and hyperthyroidism, and malignant thyroid tumor, neck lymph node dissection, especially the swollen central node lymph nodes, and receiving a second thyroid surgery, which is a redo, and resternal goiter or large thyroid mass, and also the preoperative imaging indicated the presence of transposition of viscera and subclavian artery variation along with the suspected non-recurrent angina. Patients with unilateral occult paralysis that requires IONM definitely, and patients requiring total thyroidectomy in particular and endoscopic surgery, and requiring a surgery to repair recurrent angina also. In those cases, IONM is more important. Patients requiring parathyroid surgery also, sometimes it's more important in that case. And standardization of IONM is more important in this case before starting of the surgery. It is used to guide and improve the quality of techniques and avoid many adverse effects due to improper monitoring of operation. It is used to see that actually record the vocal cord movement using a fiber optic laryngoscope, and recommended anesthesia for IONM, that is also more important, on body position and EMG endotracheal tube, the electromyographic endotracheal tube placement. That is also more important in that. This is a simple concept to show this picture actually where we are actually the electrode position, the endotracheal tube, which is inserted in the vocal cord, and when we are stimulating the now with the monopolar stimulator, and we are getting the response like this. Electromyographic activity from the right and left vocalis muscle. I'll show the another one. The IONM setup, what we usually do is that endotracheal tube mean depth, which we can be able to intubate with that, for the men approximately 20 centimeter, and for the woman approximately 19 centimeter. And also you need to place the ground and reference with the electrode impedance of less than 5 kilo ohm, and you should look into for the raw EMG pattern, and even threshold that we can maintain between 50 to 100 microvolts. The stimulation protocol, which we can use, is the active monopolar probe, which we can give it to the surgeons to be able to stimulate the nerve or near the nerve structure, and reference needle electrode on the exposed muscle, we can place it, or on the chest. The current intensity, usually we do start with the 0.8 milliamp to 1.5 milliamp of the maximum. This is a typical EMG endotracheal tube, electromyographic activity. This is a surface electrode which is placed on the endotracheal tube. This is a fluxor metallic tube. There are many variants of tubes are there, which I'll show you later. So this electromyographic surface electrode will pick up the response when you're stimulating the electrode. This is to be exactly on the vocal cord, and this has to be fixed on the connected to the system. And when you're stimulating the recurrent engine now over here in the surgical field, you will be able to get the clear response in that way. So this is the typical video which I can show you actually where to place the endotracheal tube on during the intubation. This is the typical actually woman. So we need to place around 19 centimeter intubation area. Actually, this is a surface EMG electrode, which we can place it, and it has to go a little bit deeper below the vocal cord, and we can place it, because usually the tube position is more important. Actually, it has to go a little bit inside deeper, in generally 19 centimeter, but it has to go for at least of 20 to 21 centimeter, so that when you are doing the neck extension after the before positioning of the patient, during the neck extension, the tube little bit may come out, so that it will be in a proper position of the vocalis muscle to record the response. And this is the illustrative video which we can show it. This is a vagus response when we are stimulating the vagus, and now we are going to stimulate the recurrent. This is the difference between the vagus and the recurrent. Again, I'll show you that. So this is the vagus, which usually falls between that 4 to 6 milliseconds. There is a time taken the distance between the stimulation and the recording point, and recurrent will fall into that 2 to 3 milliseconds, which is very short length. When it comes to the IONM, 4 steps are as per the international protocol and the monitoring committee for the thyroid. Actually, there are 4 steps which is more important to monitor, which is step 1, which is V1 signal. The V1 signal is to stimulate and confirm the vagus nerve at the plexus of the thyroid inferior level, which is a recurrent engine nerve. If the signal is absent, detect the vagus nerve at the plexus thyroid superior level. That's a non-recurrent engine nerve level. Once we have done that V1 signal, that is a vagus, then followed by we have to do for the recurrent R1. So before or an exposure, the EMG signal can be located using the cross method by applying the probe vertical to trachea at its traveling area and then parallel to the trachea. And followed by the R1 signal. So the step 3 is actually R2 signal. After the recurrent angina is exposed, the most proximal end of the exposed part is detected for EMG signal. Signal changes compared with the baseline, that is R1, needs to be evaluated if anything. And finally, the step 4 is a V2 signal, EMG signal of the vagus nerve detected before closing the incision. The signal analysis, which we usually do, that this is a biphasic waveform, should be differentiated from the artifact. That is more important. No other EMG parameters differ from the baseline responses. No obvious decrease in R2 or V2 signals. If the RNA is injured during the surgical procedures, detect the injury site and search for the injury cause. We need to detect the two way. It is a segmental based injury, segmental loss, or the global loss of the signal. So far, we have seen that is actually intermittent continuous neuromonitoring, which we have seen. That is as detecting this signals with the intermittent stimulation of the recurrent angina and the vagus. The other method is actually continuous intraoperative neuromonitoring, which is the stimulation of the vagal nerve was indirectly by automated periodic stimulation method. This allows the real-time monitoring of the amplitude and latency of the EMG on the recurrent angina. However, the superiority of the continuous neuromonitoring or RN percentage compared with conventional intermittent stimulation is still controversial. But still, people can be able to use it to detect the level of the injury or level of the signals. This is basic. This is actually a clip-like stimulator which we can be able to apply on the vagus nerve, and the device actually, device connection is the same, and instead of that monopolar stimulator which you are connecting to the port that a monitoring system, we have to connect this clip-like electrode, and the current intensity we need to maintain with a stimuli of 200 microsecond. So this is exactly that clip-like stimulator which is applied on the vagus nerve. So this is for the continuous neuromonitoring, and once we applied, we have to check for the signal. So this is the blue color, the background biphasic waveform is the continuous neuromonitoring with the stimulation at the vagus level. In this method, we can do that two way. So one is in between, if you require, you can do the intermittent stimulation also. And also we can do continuously with the automated periodic stimulation with that 3 stimuli per second. So here there is a system as the latency and the amplitude waveform, which usually 10% increase in latency or 50% decrease in basic amplitude. That will give the alarm. So usually that is a signal alarm which we can able to make out, and we can see for that any surgery injury induced cause. This continuous, the cons of this continuous intraoperative monitoring is actually, in some studies, the vagus nerve stimulation is associated with the cardiac arrhythmia sometimes, and bronchospasm and hemodynamic alteration. So another problem is that wide range of sensitivity and positive predictive values of the recording part of the measured EMG of the vocals must also can be seen. Since the electromagnetic activity in continuous neuromonitoring, the electrical phase difference between the two electrodes can be affected by usually the saliva or sputum in the larynx. Also, the contact between the vocal fold and the electrode can be unstable by the movement or malposition of the EMG tube or needle electrodes. This is another continuous neuromonitoring method which is recently is evolving in this field of not only the thyroid, also for the brainstem cases. This is called laryngeal adductor reflex, which we started doing now in TMH. Actually, this reflex is actually the life-sustaining protective mechanism that serves to shield the lower airways from the inhaled foreign bodies. This laryngeal adductor reflex has been extensively investigated, and its dysfunction has been linked for ranging pathology from dysphagia to sudden infant syndrome. When we are stimulating this, the EMG activity of this reflex have been used to devise a methodology for monitoring both vagus and recurrent during the procedures. This methodology involves continuous IONM of the laryngeal adductor reflex and isthmus termed laryngeal adductor reflex continuous intraoperative neuromonitoring. This is a recent technique which we are following now, but not fully implemented. This method of the continuous intraoperative monitoring of laryngeal artery reflex and is termed continuous intraoperative neuromonitoring. This laryngeal artery reflex is basically the brainstem afferent and central and efferent components. It is initiated by stimulating the supraglottic mucosal receptor stimulation. That means the afferent information is stimulating. We are stimulating afferently, and the information is carried via the ipsilateral internal branch of the superior laryngeal nerve and vagus nerve to the brainstem. I'll show you the pathway. After synapsing the brainstem, the efferent information is carried by the vagus and recurrent nerve to the laryngeal adductor muscles, that is lateral cricoarytenoid and thyroid muscles. Actually, this is another type of that, another variant of that endotracheal EMG endotracheal 2, which we can place it over here in the vocalis muscle. The stimulation which is happening, if it is a the stimulation which is happening to the contralateral to the surgery. For example, this is the basic mechanism which we can show it here. The stimulation in the right inferior superior laryngeal nerve stimulation, that is a mucosal stimulation, that is the efferent pathway. This efferent pathway stimulation which goes to nucleus solitarius tractus on the brainstem. From the brainstem, it goes to the nucleus ambiguous, which is the nucleus for the vagus nerve on the brainstem, and it comes back to the recurrent laryngeal nerve. So this is actually stimulation the contralateral to the side of surgery and recording from the ipsilateral to the side of surgery. So this pathway goes from sensory to brainstem reflex. From the reflex pathway, it comes back to the, as a motor to the recurrent laryngeal nerve. Similarly, if you are doing the other side of surgery, the stimulation on the left side, when we are doing the surgery on the right side, stimulation on the left side, it goes on the same brainstem pathway from afferent to efferent and come back to the recurrent laryngeal nerve, and the means it finally innervating to the laryngeal adductor muscles. Which will come to know, actually, this is a simple laryngeal adductor reflex. This is a single stack responses. When we are stimulating the contralateral to the side of surgery, response to the this response is we are recording from the ipsilateral to the side of surgery. And this is a single value of the response, and we can show here multiple responses actually, which we can show. This is a stack response, which we can see it. This laryngeal adductor reflex of the continuous neuromonitoring is to continuously monitor vagus, recurrent laryngeal nerve, and also the superior laryngeal nerve function. For optimal results, actually, the laryngeal adductor reflex should be used in combination with the intermittent IONM, as laryngeal adductor reflex cannot assist at nerve localization or mapping, whereas when you are going in the surgical field, the intermittent IONM can provide the clear information. But however, intermittent IONM cannot provide continuous assessment of the functional integrated of the nerve system when during surgery. So high surgeon responsiveness is more necessary to get the feedback obtained from the continuous neuromonitoring is essential to successfully prevent slowly evolving forms of nerve injury when we are using for this laryngeal adductor reflex. However, still this is in the very budding space of this technique in larger populations that needs analysis needs to refine this existing warning criteria for laryngeal adductor reflex and clarify its utility in surgeries other than neck endocrine surgeries. This technique also we can use for this vagus nerve stronoma excision also. That is more useful in this case of surgery. When it comes to this algorithm, actually, the recurrent laryngeal troubleshooting method, possible loss of signal. When you are losing the signal, when you're stimulating the intermittent or continuous, actually check the matching between the measured stimulation as displayed as monitor and the stimulation setup value, that is stimulation to the contralateral vagus nerve. If this contralateral vagus nerve is absent, and you can see for the recording side problem, that is either the tube is malpositioned or checking the recording side ground and interface connector box and monitoring the connection and take a corrective maneuver. Just consult with the anesthetist, either any muscle relaxants that have been given or recording electrodes before larynx or repush of the ET tube. And the other case of the possible loss of signal, which we can able to troubleshoot, is to monitor the display that measures the stimulation values and too low and does not match with the stimulation setup value. Usually, sometimes the resistance will be there. When you're applying for the 1 milliamp current, all the 1 milliamp current may not be able to deliver to the particular surgical field because of the higher resistance with the local fluid and the patient's resistance, as well as the patient's body resistance and the amount of type of electrode which you are using for the reference and the ground makes everything into that. If the stimulation side problem, the monitor does not return to the monitoring interface. That means the circuit should be complete. When you're applying the 1 milliamp current, it should go to the nerve and elicit the EMG response. After the elicitation of the EMG response, the 1 milliamp current should come back to the through the ground electrode and come back to the machine and go to the output, so that to make sure that entire circuit is filled. If it is not coming up when we're applying 1 milliamp current, delivering a 0.8 milliamp, or then there is some issue with that circuit among the circuit itself. We need to try to figure it out. So what is the issue there? The intensity and frequency of the stimulating current are erroneous. Shunt of liquids in the detection area present, if it is there. And we have to check for the corrective maneuver, check stimulation side divide connection and monitoring interface, and check the stimulation current parameters and keep the detection field clean. If the stimulation side problem, then we have to stimulate the contralateral vagus and to check whether everything is perfect or still there is the same issue. Then we can change the ground or reference electrode or the stimulator, or we can check the tube connection. If the stimulation of the contralateral vagus is present, but ipsilateral surgery, the response is absent, then consider there is ipsilateral neural injury. In continuation with that, the loss of signal demonstration usually shows that EMG change from initial satisfactory EMG is more than 50%. No or low response, that is 100 microvolts with a stimulation at 1 to 3 milliamp current. Also, we can consider similarly little bit as a loss of signal definition. The vocal cord movement is restricted or fixed under laryngoscope during the detection of nerve. What we can do with the loss of signal is map lesion and determine the lesion type. That is type 1, which is a segmental or signal change with injury site, or type 2, global, that is global loss of signal without injury site. Consider contralateral surgery timing and avoid bilateral vocal cord palsy usually. Thank you very much.
Thank you, Dr. Parthiban. Excellent lecture. I think this is a new, basically new technique and technology, this for most of the students. So I think there are a couple of questions, and if anybody else wants to discuss, please put them on the chat box. So one person has asked, any special type of anesthesia is preferred for these type of, for new intraoperative nerve monitoring?
No, usually actually we can do, since this is a cranial monitoring, so stimulation recording point is very nearby. So we don't need any special type, only that we need to avoid that muscle relaxants after the induction dose. And we may use the inhalation anesthesia, so up to 1 MAC. And along with that, intravenous anesthesia, if anything that they need it.
Correct. So no special type of anesthesia?
Not required, not required.
Yeah. So any chances of neuropraxia after this electrode application to vagus or any other nerve?
No, neuropraxia after electrode application is less actually, unless until the intubation has to be in a proper way to do that.
Correct. I think with continuous monitoring also, there are, I think they want to ask if continuous monitoring or versus intermittent monitoring would make any difference. Dr. Parthiban?
Yes, yes. Actually, intermittent monitoring is actually what we are routinely doing is to map the rectal angina during the surgical field and try to identify and trace the nerve during the course of surgery. But when it makes actually, when we are doing that intermittent, we do not know suddenly where we made the injury to the nerve. If it is, so sometimes we may not aware of that suddenly. So, and without knowing that, actually we can go further for the dissection. And And later on, actually, maybe after 5 minutes or 10 minutes later, when we try to stimulate there, that time, so you may not get the response with that because you already made the injury. But in the case of those cases, actually, it is better to use, along with the intermittent monitoring, it's better to use the continuous neuro monitoring. So it will tell immediately the feedback of that status of the recurrent angina now integrity.
Correct. I think somebody has asked, is scoline best for induction? What is the cost of this? I think
no, the scoline is a very short acting muscle relaxants. Actually, you can use that actually atracurium also, because for the induction dose. So because the atracurium will come actually induction dose for lasting for 20 to 30 minutes. That is more than enough, because within 30 minutes, actually, after that, draping and cleaning, everything is there, and raising the flap, everything. In the 30 minutes, that will cover. After that, you should not give any additional thing, because if you are giving additional muscle relaxation, that will be really a problematic, not a problem. That is a really, when we are stimulating the nerve, we may get the very low response, which may not be able to clearly predict that what is the exact status of the nerve structure.
correct. So, Dr. Parthiban, in your this vast experience with the technology and with the instrument, would you suggest the students and the residents to be routinely using it for all the cases, or should they be still be choosy in using it for selective cases? Though you have told us the various indications, but what about your personal experience?
It's two-way actually. So I can say, in my point of view, till you are exposing your anatomical and surgical skills, it is always, this is actually added tool. Actually, you can utilize wherever you are required and whenever. Once you are comfortable, then you can decide whether you can use it for a particular case or you can use it for other case. So here we are routinely doing for either for a direct thyroid surgery and also for the complicated surgery, and whenever the surgeon requires also, because its availability in our institution is much pretty here.
Correct. So, Dr. Parthiban, with this, I think there is one more question. So, I think I would ask this: if we do it like a procedure for each case, generally, what would be the cost? Because how costly is the instrument for this thing which we use in our routine setting at
The
TMH?
instrument cost is instrument cost is minimum, it comes on 25 lakhs. So in a recent setup, and in added to that, actually, each tube which you are using is the tube cost is around 17,000, and stimulator is another added cost 10,000. But stimulator we can use for the multiple times. We can reuse it actually, and that is maybe actually, as far as that stimulator is good and enough to clean and give it to the sterilization, we can use for multiple times, more than 20 to 30 patients also. But in the case of tube, depends on that. Actually, there are two types of tubes are there. One is that inbuilt electrode, which comes as a tri-vantage. So that is not user-friendly to reuse it. But there is another tube called the flexometallic, which is a surface electrode which is placed with that. So that can be reused. So what we are doing routinely in a large number of things in our center, we are reusing for the most of the patients. Till that minimum, I can reuse the one flexometallic tube, which comes for 5 to 6 patients. So the cost of the tube is approximately 17,000.
And that same tube we can use multiple times?
Yes.
After, okay, 5-6 times we use.
Yes.
So with this, we come to the cost around 3,000 per case. And if we have the instrument, so if we say in a private setting, I think cost also would be a concern. But I think if it is reusable, probably if we do a cost benefit analysis, probably that will be superior, because the injury to the recurrent laryngeal nerve will have more implications. So I think there is a study you are doing with Gauri madam also regarding this is a randomized study which Dr. Gauri and Dr. Parthiban is doing in TMH, where they are basically comparing the use of IONM in thyroid cases versus those where IONM was not used. So are there still the analysis is going on, or do you have some idea about the results, Dr.
No. Still the trial recruitment is going on. So we have not gone into that. This is a 5 years study, the randomized control trial. So which we have started almost at 1 year, 6 months got over. So still we are doing it actually.
And we are doing the cost benefit analysis also. I think that will be difficult because we have our instrument and we are using it multiple times.
Yes. No, we are not doing that one actually. right now.
Yes.
Yeah.
Yes. So I think it's a great technology, and we personally are also using almost nowadays whenever it is available. We are using it for our routine cases, and I would say, as personally, I have done lot of cases myself without IONM and with IONM also. That IONM is a great technique. Whenever available, we can use it. But to the budding surgeons, one advice is that technology is always to help us, and it should not be used as the sole way to identify the nerve. So you still have to use your landmarks, the surgical landmarks, a meticulous surgery, minimal use of cautery, but along with that, use of IONM will give you a lot of confidence, and the most important part will be the planning and counseling of the patient in the post-operative period. So I think it is a great technology, and we should be well versed with it. So if there are any other questions, we would go ahead. Any more questions? So if there are none, with this, I thank Dr. Parthiban. Thank you, Dr. Parthiban. Great lecture. And I am really sure I at least learned a lot. And thank you once again, Dr. Parthiban.
Yeah, thank you, Dr. Poonam. Thank you for arranging this meeting.
Thank you.